Hello, everyone. Good evening. Today is the last day of February, and we are continuing our series on which we started on World Cancer Day, which was on 4th of February. And today's topic is improving health outcomes in cancer care. We strongly believe that patients and their family members need to be better informed, and the more informed they are, the more they will manage their health. Um, and that's what PatientsEngage is about. It is an online platform which helps people make decisions easier, as well as it's a platform where patients and caregivers share their experience. We've always kept patients and survivors at the center of all of our content, and you can find all of our content on our website as well as our social media channels and YouTube page as well. Um, Part of this, as I said, is the third of the series, which is being supported by Pfizer on World Cancer Day, on being better informed to manage cancer better. That cancer is a condition to be understood and not feared. So we looked at the key questions to ask when you're diagnosed with cancer. We talked about how innovations have in cancer care have changed over the last few decades and how they affect the quality of life of patients as well as survivors. As I said, today we have a very esteemed panel. We've got with us Dr. Jyoti Anand, who may need to leave a little early. She's consultant medical oncologist at Yashoda Hospital in Ghaziabad. We have Dr. Chetna Bakshi, consultant medical oncology and bone marrow transplant at Jupiter Hospital, Mumbai. And we've got Dr. Anuradha Daptardar, in charge of the physiotherapy department at Tata Memorial Hospital in Mumbai. And I am Aparna Mittal. I'm founder of PatientsEngage. So as you can see, we are focused on, not just medical care, but also the whole holistic care and psychosocial as well as rehabilitation. Um, Reminder that this session is supported in public interest by Pfizer, and the content of this video is meant for informational and awareness purpose only. It does not substitute medical advice, so please do consult your doctor or your physiotherapist in this case for guidance on the based on the information you collect here. The views are that of the speaker or the panelist, and Pfizer may not endorse the same. They may not also reflect the views of the platform PatientsEngage. As I said, this is meant for general awareness. It does not replace a medical consult. We are live on Facebook and YouTube, so you can post your questions on Zoom if you're here, as well as on Facebook and YouTube, and we will address it. If you post it later, we will still try and respond back to you, or you can always write to us at editor@patientsengage.com. So thank you so much, to our panelists for joining us today. Let me start with you, Dr. Jyoti. The focus really of this session is, most cancer patients eventually do want a better overall survival as well as a reasonable quality of life. And, sometimes we struggle to balance that for cancer survivors. But let us look at what are the factors that affect the overall survival of cancer patients. And we know that in India, our overall survival rates are much worse than some of the advanced countries. So if you can, Dr. Jyoti, start by talking about some of the factors that affect the overall survival.
Hi, Aparna. Thank you. Thank you for having me on the panel. So I think that is a very important question every patient should understand, because in our country, cancer or any other disease for that matter is a social taboo at least. So first thing that matters is do not keep it to yourself. Go and consult your doctor. So that impacts the staging of the disease. Disease which has been diagnosed at early stage, which has been diagnosed by screening, the survival definitely differs as compared to a disease which has been diagnosed at a later stage, because we were keeping on hiding it and keeping it under no, I don't have cancer. We don't have acceptance that we have cancer. So that is the one factor. And second factor is obviously finances. Let us say one has come to know that yes, I have cancer, but now how will I go ahead with the treatment. I don't have finances. If you talk about a middle class person or a lower income group person, he will earn his daily wages to just keep his or her home running, or he will spend his time as well as hard earned money on the treatment. So that is another important factor in our country, which actually affects the survival of the patients. And definitely the burden of the disease and the treatment availability, like a patient who has been diagnosed with cancer. Just a second, Aparna.
Sure.
So a patient who has been diagnosed with cancer, but due to logistics, he has been in, he want to take treatment, but non-availability of higher end treatment is another factor which definitely affects the survival.
Right, right. Thank you. Anything else that you would like to add to this, Dr. Chetna?
No, I actually completely agree with her. I mean, what she said is 100% true. Compliance is something which we are facing very big problem. Secondly, I mean, in our India, cancer research centers, cancer centers, treatment centers are located only in few major cities, and people find it difficult to travel from. For example, in Bombay, we have TMH, so people find it very difficult to travel from remote villages. So, what I think is personally, there is a need for decentralization of these centers, and we should have big centers at least in every town, which will definitely help to improve the survival.
Right. So I think that there has been some progress. You now have more regional cancer centers. You now have cancer centers,
Yes.
cancer hospitals. At least some part of the treatment is available in smaller towns as well. Things like radiation, I think, is still a challenge in in remote areas. The one area that I would like Anuradha ji for you to touch on is the challenge in terms of access to supportive care.
Yeah. So supportive care, is a very imperative thing when it comes to treating cancer patients. And this support is not only from the family members and the caregivers, but there are a lot of other social factors and environmental needs, and some factors which we really don't look upon. So what I feel is the major social support that we can really get for these patients is to have a good social service department, and involving the medical social worker as a team in the multidisciplinary part of cancer treatment. Many areas and many hospitals and many peripheral centers don't really have this access, because I think medical social workers do wonders. They not only financially help the patient, but they look at a lot of other environmental factors, like they look at the transportation, they look at the accommodation for these patients. And I think these are major issues when it comes to treating a cancer patient. So apart from the family, there are other aspects which the patient always worries about when he is diagnosed with cancer.
Right.
And another, as a rehabilitation therapist, I feel that there has to be more rehabilitation therapists who are trained in treating oncology care. That is also one lacuna that we are really looking. And I don't know, unfortunately, I feel that be it physiotherapists or occupational therapists, oncology is not a really big topic or subject that is included in the curriculum, with the result that not many physiotherapists and occupational therapists are really having some keen interest in this. But of course, I would say that slowly this field is evolving, and now many therapists are slowly trying to find the way into oncology. So I think that will gradually change their scenario.
Yes, in fact, all our patients will require physiotherapist or occupational therapist. That is need of that time. We can't do, I mean, without them. We need them for each and every of our patient.
True, true. Yeah. So I think that is a very valid point, Anuradha ji, because I think one of the things, like, people associate physiotherapy with essentially, bone related issues. So, knee replacement, hip replacement kind of thing, or aches and pains, but don't understand the role of rehabilitation and, both physio and occupational as well as psychosocial support for cancer care. I think we've just lost Dr. Jyoti. Okay.
I'm here.
Okay. So just wanting to again, let's unpack, in the opening statements, you'll have all talked of the various challenges. So if we look at each of you can focus on one aspect. Dr. Jyoti, I'd like you to touch a little bit on gender and social barriers, especially because you come from a smaller town, which is quite close to Delhi, but still a smaller town. So if you can, in your experience, how do you see that affecting timeliness to diagnosis?
Gender is very important factor. It not just in, yes, I am working in Uttar Pradesh, right? They have a strong this thing for gender, but definitely in every part of India, it is not found to be missing. So this is a very important factor because many of the females, they don't want to go to a onco surgeon for having a breast examination, or if the patients, like we have higher incidence of breast cancer or then a cervical cancer, if we talk among females, then for cervical cancer, they definitely will not go to a male doctor. And especially in remote areas, these are very common problems where we have only, they don't have choices of doctors. They have just few doctors. So gender is definitely one problem. And second question you were asking was?
So other social barriers in terms of, so how does this affect the timeliness of diagnosis as well as access to treatment? If I look at
social barriers, like I told you that cancer is just like tuberculosis, it is a social taboo. So whenever we discuss among, suppose sometimes we find breast cancer in young females also. If a girl will go to her mother, will tell her that I have a lump in my breast, rather than taking her to a doctor, I tell you the fact that they will definitely try to marry their daughter so that it actually they get rid of that, and the daughter will suffer in their family. So this is the status, this is the heights of ignorance in our society. This is very important.
Right. Thank you. And Dr. Chetna, I know you talked of access both from a location perspective, but also we've talked a little bit on finances. So again, can you elaborate a little bit as to, so do you see that affecting the initial treatment, or you see that affecting more the ongoing treatment of cancer care?
So both the things, like for example, if we take finances, many people, those who do not have health insurance, even middle class, I'm not talking about the poor class, even middle class, lower middle class, they would not like to come to oncologists with the fear key, because everybody has this, and which is true also, that oncology treatment is very expensive, because obviously nowadays newer therapies are more expensive, they are patented drugs, and they have heard from everybody. So they do not want to come just thinking ki mujhe to cancer ho gaya hai, I will die, but I want to keep this money for my children. That is the reason they won't come. So this is actually a major barrier. So when they come, we try and tell them, okay, no problem, even if you do not have money, we have a social worker, go to social worker, and then you can go to trust. Secondly, people have this it's a weird kind of thing ki, okay, we don't want to beg. So it is like begging. So it's not begging, it is just taking help from somebody which is for you yourself. That also many times. Thirdly, in India, I would say in India, but what I
Your
have seen is
experience.
many people, they come to the doctor, they want the treatment, but they don't want to take efforts to go to a trust or ask for money. They'll say, "मेरे पास इतना है, करना है तो करो, otherwise okay, I will die. I will die. I'm okay to die." So all these things in finances is very, very important issue, and most of the people, they do not have health insurance, and they find it very difficult.
Right.
Yeah, Aparna ji, I have a point to make here. Like
Sure.
What happened in my clinic today only, I found a patient came in OPD that he's a case of a recurrent CA tongue, and he was having the stridor. He was having difficulty in breathing. In layman language, he was having difficulty in breathing. So I immediately said, see, this is an emergency. You have to get admitted, right? That particular patient, it has a government panel, but now they cannot get him admitted because one of them has to stay with him, and then his job will get affected. So this is the status of finances in our country.
Correct.
They literally took the patient back home, give us some medicine, we cannot get admitted. He was counseled, no, his bills will be reimbursed, or it will be cashless. But no, they didn't get admitted. So this is the status.
Yes, that's true.
Yeah. No, I know these are, I mean, the challenge of the loss of income to a caregiver is also a huge factor that comes in. Anuradha ji, in terms of you talked of rehabilitation. Can you explain what is cancer rehabilitation? Because I think often people don't know what is cancer rehabilitation. So if you can just kind of explain what that is.
Yeah. So actually, cancer and its treatment, it causes a lot of morbidities, basically. So it is not that the suffering of only the disease, but the suffering that is caused because of its treatment also. That means
Mm,
treatment like the chemotherapy, it has got its own side effects. The radiotherapy has got its own side effects. Even surgery, that it leaves with a lot of disability and dysfunction and everything, so basically, rehabilitation means it is like focusing and making the patient back to independence, functionally independent. That is what in short rehabilitation is. So in cancer also, it is when it comes to treating a cancer patient, you put it as a cancer rehabilitation. That means addressing all these morbidities which are caused not only because of the disease, but also because of the
Treatment.
treatment. So chemotherapy has like neurotoxicity. So there is peripheral neuropathies, which is a challenge to these patients and they suffer. And there are some ways in which rehabilitation can help.
help.
Also, surgically, the patient is left with some dysfunction, there can be a neck dysfunction, shoulder dysfunction. There can be a dysfunction of their extremities when it involves bone tumors. So, putting this patient back on feet and allowing them to do the ADL activities, daily living and the simple basic needs and activities. That is what is the role of rehabilitation, and that is how we will focus on these areas, so this can be basically not only post surgery or post treatment, but it can be something that can occur when the patient is diagnosed. So before the
Mm,
patient goes in for a treatment also, we can do something called as a prehabilitation, which is nothing but preparing the patient for the treatment, so we see that, like, suppose for the patient has to go for surgery, then fitness is one of the major issue. So then we can see the functional capacity of the patient by doing a basic simple walk test. And then on the basis of that, we can give some exercise prescription to these patients to see that, they have that complete fitness before they go, because we know that surgery is definitely going to cause some kind of weakness post-operatively. So we are
right.
trying to target that pre-operatively. Then that goes for the chemotherapy as well as for the radiation. And after treatment, that is after the treatment or during the treatment course also, they come up with various problems. That is where again the rehabilitation comes in picture.
Right.
And
Right.
last but not the least, when they go in for palliative treatment, like that is when you say that is the end of the care, even at that time there is a role for the rehabilitation therapist, the physiotherapist have a big role there,
Role to play.
because there it is like we don't have to set any goals or we have to achieve something, but there we are firmly believing that reducing the distress level and reducing the discomfort of the patient itself improves a little quality of life at the end of their journey.
Right. Asking both you, Dr. Jyoti and Dr. Chetna, we talked of rehabilitation, and I suspect, Anuradha ji, this may be even more common for older patients, geriatric patients as well. So again, in your practices, Dr. Jyoti, do you see a need? Do you recommend rehabilitation for a certain category of patients? Is it, and how often? Because I also know that in some sense, prehab can be a luxury because you're trying to start treatment ASAP because the cancer is already advanced. But, are there cases where you still go ahead and recommend rehabilitation?
Rehabilitation actually came for surgical patients primarily, and definitely it is needed because chest, they need a good pulmonary function, so they go for spirometry and all that. And for limb movement also, they need the physiotherapy or supportive care to be started earlier before surgery. In our practice as medical oncologists, it is not that common. But my personal belief is that, what is the difference between treatment being given in India or being abroad? Why celebrities are going abroad, and what is the difference? So I feel the major difference is the holistic approach from day one, from the date of diagnosis, or maybe earlier also, when the diagnosis part also starts, patient should be, because it is the major, it is a critical time when they actually need not just physical rehabilitation, mentally they need to be strong to get themselves tested, to face the results. So it is actually very important. And it should be made a routine to tell the patient to go and meet this particular doctor. Or cancer care hospitals, especially standalone cancer hospitals, they should have a separate department, dedicated department to look into all these things.
Right.
Right. Dr. Chetna, would you like to
Yeah.
add anything?
Yeah, so as she said, I mean, we need a cancer counselor. So in our hospital, we have a counselor system where when the patient gets diagnosed, patient is specifically, I mean, we call a counselor, and the counselor will speak to the patient not regarding only the treatment, finances, or outcome, to make them prepared for the outcome. And this is required not only for the patient but for the patient's relatives also. And when patient is admitted, sometimes, as she said, for the palliative care. So it is very, very important to make them ready for end, how the end is going to come. They have to, how they have to face it and how to accept it. So we have this counseling system. Then we have some people coming and doing some kind of yoga therapy, music therapy, all those things we do in our hospital, which helps many of the patients.
Right. Thank you. So after the intensive period of the initial treatment is over, which is, what is a typical expectation from cancer treatment, although now less and less so. But, there are certain cases where you may be putting patients onto ongoing treatment as well, right? Because there may be ongoing hormone therapy or targeted therapy or some of the other protocols. Can you kind of shed a little bit of light, Dr. Jyoti, on the type of ongoing care and what are the factors that influence those treatment protocols?
Maintenance. Sorry, maintenance. You are asking maintenance treatment.
Yeah, I guess maintenance, and in some cases they're not just maintenance, right? So yeah.
Maintenance treatment, when we talk about, I think in adjuvant setting or like this curative setting, we can say in palliation, it is kind of treatment which is continuing because we don't have any goal to reach. It is just a reevaluation based treatment. So challenges are in maintenance treatment are definitely compliance, as Dr. Chetna earlier discussed, because patient will tell you, if a patient is on targeted therapy, we all know that targeted therapy does not have any duration for this one duration, especially in palliative setting. So patient feels that, why, if I'm disease free, why should I continue the treatment? But we do not have actually goals, predefined goals, that this is the limit, here I have to stop. But we have the fear that disease will recur. If we'll stop the treatment, disease might recur. What we are looking at is that we have a good control of the disease, but what patient is looking at is that she has to come or he has to come, he has to get admitted, he has to take the treatment. So this is the major challenge, that compliance and understanding. And I think finances comes here, logistics comes here, definitely. And this list is never ending. Everything comes in, family comes in, abhi to bachon ki shaadi karni hai. So this list is never ending, I think.
Right.
And once they see the PET scan coming normal, they're all interested in continuing the treatment goes off. Abhi normal aa gaya, you are just giving treatment like that. That is what.
Or we can increase the duration. You can make it 15 days. You can make it 1 month, 2 months. Right. Just like
Right.
And when it comes to rehabilitation, at least they have some symptom, and that symptoms have to be taken care. The disease has to be controlled. So at least they go there. But in rehabilitation, still the patients don't understand that why we have to continue doing these exercises. Now my treatment is over. Now I don't have to, I can have a laid back. So for us to really convince them, this is a requirement for you, which you may not realize now, but you may find it important later. That is another big issue that we are also facing.
Yeah. No, I know. So let's talk a little bit about the common long-term effects of cancer treatment. Dr. Jyoti, again, if you can talk a little bit about some of the common long-term effects of cancer treatment and what patients should be aware of, things like osteoporosis, etc. So if you can touch on those.
See, we are very this thing ki medical oncology or chemotherapy is the worst treatment in cancer care treatment. Surgeon will do one-time job and no side effects. And radiation, it has just short-term side effects, but long-term side effects of radiation we all know. So major part of counseling comes to us, and in which major is the hair loss, I think. And they need to be counseled. No, it is just temporary. Hair, nail and skin changes are just temporary. Osteoporosis is an important part, especially we talk of hematological malignancies where we give a lot of steroids. Osteoporosis comes, we need to face this osteonecrosis of jaw, giving this bisphosphonates, and femur fractures. These are very common problems. And definitely patient will, neuropathy. Neuropathy is again one common problem with almost all the chemotherapies which will come. Auto toxicity with the cisplatin treatment, and then nephrotoxicity of certain drugs is also to be considered. So I think all the systems are getting, and if we talk about targeted therapy like trastuzumab, so these have
let's not mention brand names, molecular names. So.
Okay, sorry. Like targeted therapies, they have cardiac effects also. They decrease the ejection fraction. So these are the long-term toxicities, and some patients actually do not recover out of these side effects.
Right. We've lost Dr. Chetna. Hopefully she'll join back. But Dr. Okay, she's connecting. Dr. Chetna, can you talk a little bit also on, are you back on, Dr. Chetna? Not yet.
Can you hear me now?
Yes, can hear
I'm
you.
back. Sorry. Yeah, sorry for that. Yeah.
No problem. Can you also talk a little bit on, because we've had patients who've talked about premature menopause and brain fog as well. So if you can talk of those side effects, she's gone again. Okay. While we wait for Dr. Chetna to come back, Anuradha ji, can you talk of, what can be done in terms of rehabilitation for osteoporosis and neuropathy?
Yeah. So actually osteoporosis, to prevent osteoporosis, normally we tell them that they go for this weight bearing exercises, because when you put load on your bones, that time it is like the bones, the calciums and all, it absorbs well and the bones become strong, so normally we recommend the weight bearing exercises and strength, that is the resistance exercises majorly for preventing osteoporosis. But if once osteoporosis has set in, then we have to go for a little guarded exercises, and probably it may, depending on how much the bone density is or demineralization is. So depending on that, we may probably have to give some supports, or we may have to give some kind of aid for these patients so that they can offload those joints, and we can prevent some kind of a fall or impending fractures, if it is set in. Other than that, they can go for some assisted exercises, instead of the high impact loading exercises, they can use chairs. They can sit on a chair and they can do some exercises for their upper limbs or anything, in case if they have got osteoporosis set in at the lower bones or weight bearing bones. So there are different modifications and modified ways that we can give. Then we say that instead of using free weights, instead of using a dumbbell, which is more prone to cause some kind of a fracture if there is osteoporosis, then in those cases we can ask them to go for some resistance bands, with low resistance exercises, which can prevent these kind of damages, basically.
Right. Thank you. And for neuropathy, Anuradha ji?
Yeah. For neuropathy, see, most of the neuropathies that we see, they have the sensory component is much more for these patients rather than the motor. So when motor is there, we can directly go for strengthening exercises, and we can go for the active assisted exercises or passive if there is no motor function, or we can give them some kind of a support where they can, which will enable them to walk and work and use their, small, peripheral muscles and all that. But the sensory aspect is one that is the most problematic, and that is where, because the patients sometimes don't feel the ground, so walking and risk of fall increases and all. So basically it requires a lot of counseling. We do a lot of desensitization techniques we use. That means we are exposing the skin to different textures, and trying that skin and their sensations to get adapted to that things, or we ask them to wear some kind of a protective shoes or protective this, so that they are supposed to avoid walking on an uneven ground, or be more careful and use some kind of a aid when they're walking on an uneven ground, so that they don't lose their balance, because balance issues are always there when they have this sensory
neuropathy.
Yeah, so adaptive management is much more when the sensory involvement is there.
Thank you.
And I think since cancer outcome is improving day by day, we are getting more and more long-term survivors. So now there are some side effects which are long-term side effects. Those should be given importance. Like some patients, they come with cardiac failure 5 to 6 years after the treatment is over, or this primary or secondary amenorrhea. The patients, if teenagers have been treated for cancer, then sometimes they'll end up with primary amenorrhea and a lot of endocrine problems. So these are the problems which are now seeing more and more because the outcomes are better.
Correct,
And we have
correct.
to be more prepared to face this and treat these things now.
Correct, correct. So the one thing we were talking of, Dr. Chetna, when
Yeah.
you kind of dropped off was
Yes,
also
sorry.
premature menopause, because
Yes.
we
Yes.
have often younger
Yes.
women getting
Yes.
cancers.
Yes.
And also if you can talk on brain fog.
Yeah. So premature menopause, it is very, very common because whenever we give chemotherapy to the patient, it will cause ovarian suppression. And patients who are, in that gray area at the age of 40 and all, they will attain menopause. But however, in these patients, we just give them calcium supplements. Most of the times, we do not really advise hormone replacement therapy. I'm sure Dr. Jyoti will agree with me. We don't really give too much of hormone replacement, but we would like to give them calcium supplements and vitamin D supplements. And sometimes these people, they may get emotional lability for which they need help.
Right.
Brain fog, I didn't get you. What is the?
So there's often patients talk of more forgetfulness. So it's called brain fog, where they kind of think that they seem to have more memory issues. They seem to feel a bit more confused. I think Anuradha ji is nodding her head. So
Yeah.
So maybe she can answer that.
yeah.
Actually, the thing what she told, Aparna just said is right. Like, because some of the post chemotherapy patients, and especially in the geriatric population, like, geriatrics otherwise also have a cognitive, a small percentage of cognitive
Decline.
involvement, like, decline. And that gets impaired more when they are subjected to chemotherapy, which we have seen, like, and observed. So many of the patients are referred to us for cognitive rehabilitation. And now we have a recent addition. We have got a virtual rehabilitation equipment, like, in our department, which functions on these cognitive, takes care about these cognitive needs. So they're just like gamings, like, gaming area, like how children play game. The same way it is, like, it improves your memory, it improves your, coordination and your reflexes and all that, like, so that is how basically we are training and treating these patients, because they have complained that they can't sometimes remember the day, they can't remember the date, sometimes they can't remember what they had for breakfast, and, like, that is what we see. And it is more common in the geriatric and in the advanced cancer patients, like, so off late now we are actually planning to put in do some research in this field to really see what the incidence and prevalence is and how much of rehabilitation outcomes can we really achieve. So that is, we have already discussed it with the geriatric team, and I think we will be entering into that field, like,
Right. Thank you.
Nice. That's nice.
So, Dr. Jyoti, in terms of follow-up, right, especially for post-treatment, that is another important element, which is again a challenge because, again, people are coming from remote places. As you said, sometimes they don't understand the concept of follow-up or the value of follow-up. But typically, how do you advise patients on follow-up, and how do you convince them why they should, stick to the follow-up protocols?
For a follow-up, we can convince them that your repeated follow-ups are needed so that we can early diagnose the relapse and treat it accordingly. And maybe in that particular stage of relapse, it is totally curable. Maybe you will not require chemotherapy. And most of the times, our first follow-up is at 3 months, and in which we can go for imaging and all that. But patient counseling is very, very important, so that they can come for follow-up. Most of the times, actually, they do not come for follow-up because it is kind of now like freedom for them that now we are fine. जब आएगा तब देखेंगे, वो वाला जो attitude है, it is very bad.
Hmm. Dr. Chetna, anything that you would like to add
Yeah,
on?
and
But
actually they don't want to
just
come for follow-up because they're afraid kuch nikal jayega. So if I do X-ray, maybe
actually
something will come out. So might as well, ignorance is the bliss
time
kind.
मिला
So
उतना
yeah, so that's what we'll
Yeah.
see.
So
But
that is,
nowadays, at least in
yeah.
cities, compliance is improving. It is now better and better as compared
Okay.
to previous years. So definitely everything is changing now.
Right. So I think as people are better informed, hopefully they will,
Yes,
start to
yes.
see that. And I think there is, what we've seen is that there is actually, everybody calls FOMO, fear of missing out, but there's actually fear of finding out as well.
Yes, yes.
So I think often we, think that people will want to find out early, but in reality, there is this fear of finding out and they will avoid doing the diagnostic tests and so on as well.
Hi, Aparna.
Sorry.
I just need to leave, please.
Sure. Thank you so
Thanks
much,
a lot.
Dr.
Thank you,
Jyoti, for
Dr.
your
Chetna.
time.
Okay, bye.
Bye, Anuradha ji. Bye.
Yes, bye, Jyoti.
So, Dr. Chetna, we also with a lot of the cancers, and this I'll ask you also, Anuradha ji, later, but, people have a lot of things like body image issues. There are, for head and neck cancer, the face gets affected. Some things need prosthesis, you need stoma bags, etc. What is the effect of this that you see on patients, and, what kind of support should be provided to them?
So, in fact, body image is the major hurdle. Like patients do not want to take chemo just because they think that I'll lose my hair, I'll not look good.
Mm.
So they need a lot of counseling, and now there are things are available, like we have a scalp cooling cap with us which helps. It may not help patient too much, but at least initial inertia goes off and patient starts on treatment. Once they start on treatment, and even if they start losing hair, then they continue.
Then they're
So
okay.
to at least to start with, those scalp cooling and all those things help, even if they may not help in not losing their hair, but it helps. So yeah, patient needs a lot of counseling. And for head neck, we keep on telling them that one has to go to doctor immediately. If you go to doctor in early stages, then cosmesis may not be a major issue. But if they come with advanced stages, then you really can't help it. Those patients require a lot of counseling.
Right. And do you see, or do you kind of see increasingly more oncopsychology or psycho-oncology as well for patients like that, or support groups that help patients like that? What can be done to support them more?
Support groups are, it's a double-edged sword. I
Mm,
have some patients, very frankly, I had some patients whom, I encouraged to join the support group. And I thought that when this is really what I have faced, that this patient will go to that group, everybody will tell their stories, and then maybe she'll feel motivated. Exactly opposite happened, because she got so depressed hearing other people's story. So I personally feel that rather than this is one odd thing, otherwise most of the patients it does help. But what I personally feel is one to one discussion is very important. So I have some patients, thankfully there are many patients who are cancer survivors who have taken treatment. So those patients, they come forward and they
right.
say ki hum aapke patient se baat karenge. And I'm
Mm,
fortunate to have 5-6 such ladies who have gone through it, and they voluntarily they will come to the hospital. They'll ask, doctor koi patient hai jisse main baat kar sakti hu, and then we ask them to talk to one patient and a patient and a relative, and then patient feels very good. So that one to one talking really
is
helps
better.
rather than a support group. And such ladies, and there are many people who are ready to help out. They are very, very,
True.
that way we have very nice society. People are willing to come forward, and patients also, they will believe the other patient more than what they believe the doctor. So if I tell them ki nahi, chemotherapy is not that difficult, they won't believe, because they will think that she is trying to sell the product. So if
Right.
a person who has undergone a treatment, and if she goes and tells this is what I have gone through and this is what I have helped myself, how, so it helps. So one-to-one counseling from the patient to the patient really helps.
Yeah. No, I think that's an important point, and I think the right matching of the the counselor to the
Yeah,
patient is important.
right.
Because we've also had cases where somebody's come back because they were connected with somebody, and that person was metastatic late stage, and then it didn't end well and then got very
Yeah.
depressed. So
So one thing they have to understand, and one thing we should make them understand is everybody's cancer is different. Like you
mm,
can't compare. वो ठीक हो गया मैं नहीं हुआ या फिर वो तो नहीं हुई तो how I will get. So these things automatically come into their mind. So this is
right.
actually very dicey situation putting them into those kind of support groups. There are some diseases which are easier to discuss. Like for example, in Bombay we have the CML support group where we
Mm,
know outcome is good. So they are very happily they meet each other and all and they say कि नहीं हमको सबको blood cancer है but we are happy. So for some diseases it is okay. For some diseases it actually is difficult.
right, right. Anuradha ji, would you like to add anything to this?
Yeah. So actually, it's a different scene because I work in a very premier cancer institute, like, where we have support groups in practically all the areas and fields, like, and as Dr. Chetna said, I agree to her that it's like a double-edged sword, like which can work either ways, like, but one thing is for sure, like, the support group, if it is it is like, the support group should include a survivor, should include a clinician, and should include a social worker, like, so if
Right.
it includes a multidisciplinary team, then I'm sure that the people's queries and answers can be addressed, like their fears and everything can be quelled at one
Right.
end, like, and it will not cause a lot of confusion. Okay, because the survivor stands and, like, gives a very positive kind of a feedback, like, because she says shares the experience, and everybody considers her as one of them, like, and they can interact with her in a better way. The clinician is there to answer and take care of all the fears that the patient may have regarding the disease and the problems or the complications and everything. And the
Mm,
social worker can assist by saying that, what are the different areas and arenas where there can be some kind of a support, that these, whether be it social or financial or accommodation or transportation or something. So I always feel, whenever you're talking in terms of support group, it has to be very multidisciplinary, because
Yes.
everybody's needs and everybody's fears are totally different, like, and I'm sure that, like, when these things are answered, and the patient automatically feels more comfortable and, like, can justify his treatment, like.
right.
Right.
Thank
True.
you. Thank you. Just one more question to you, Anuradha ji, is, we've talked of rehabilitation and role of physiotherapy for bone health, osteoporosis, etc. Can you also talk about it, whether it's exercise, whether it's physiotherapy, in terms of fatigue management, because that's something that, doesn't get talked of as a side effect, but actually it affects a lot of patients.
Yes. Actually, it affects 80% of the cancer population. That's what
Hmm,
statistics says. Like, at some point of the time during their entire treatment, or sometimes even after completion of treatment, and many months or many years later also, there is a small proportion and percentage of population who are still affected by cancer-related fatigue. The
right.
major thing is first to understand about cancer related fatigue. There is always a confusion between cancer related fatigue and the general tiredness and,
Hmm,
malaise
hmm,
and fatigue which the patient feels otherwise because of the disease. So where you have to look at all the medical profile, and you have to look at, what the patient's complaints are like. It's not like that if the patient is unable to do, and even in spite of rest, if the patient's symptoms don't get elevated, then in that case you say that yes, this is something called as cancer related fatigue. There are different tools which you can give, like a brief fatigue, where you just 4 questions, the patient answers, and on the basis of that, that's an outcome measure which you can understand whether the patient has got fatigue or not. And another thing is the energy level of these patients, because
hmm,
fatigue is different for different patients. So whenever we have to give any kind of exercise or give any kind of activity, understanding the level of fatigue is very important. The activities that is going to cause the fatigue for these patients, the time of the day when they are more energetic, and the time of the day when they are less energetic. So, pacing and prioritizing the activities, they are very important. So
right.
which activities are essential for the daily needs of these patients, and which time is the best time when they can do this, which causes minimum fatigue. So that is what we have to see. And this can be done by just asking the patient to note down all these in a fatigue diary, so that we understand, and accordingly we can give them different energy conservation techniques or some simple exercises, simple walking, encourage them to walk, do some breathing exercises, some relaxation exercises. All these helps in management of fatigue. And that management, I think, is very important, because there are a lot, fatigue also has an important, it affects a lot of survivors also. So, and they feel that, they, when they do some strenuous activity, or when they do something like, their bodies are not able to cope and all that. So I think building up an endurance and like, developing or conditioning their system is very important, so that they don't face this problem, like,
Right. Thank you. Dr. Chetna, would you like to add anything?
No, I think I 100% agree with her. This is very important.
Right.
And there are two types of fatigue. One is mental fatigue and physical fatigue. And there are two different things which we have to identify. Sometimes
Right.
patient is mentally fatigued but physically good. And just because of that inertia, okay, I'm fatigued, they are not doing anything. So I think once we differentiate and once we diagnose, it is little easier to tell them what is to be done, what needs to be done.
Right. Yeah. So I think that is one of those chicken and egg things, right? So if you
Yeah.
actually move around more, that affects your mental well-being as well.
Right.
So, and we do have a culture in our country of kind of asking patients to rest all the time. And if they're older patients, even more so. So,
Right.
one of the things we always tell people is that let people move around, exercise, do activities of daily living as much as possible, and
So, yeah,
stay
specifically,
engaged.
specifically for cancer patients, they will just keep them in a room and they won't allow them to come outside. So, yeah, we keep on telling them, "Nahi, let them go for a walk, let them go outside." Yeah, but this, we have this thing.
Yes, yes. So that's one of our, I think, cultural issues that we
Yes.
need to keep addressing.
Yes.
So we've talked of, some of the challenges, we've talked of what some of the things we can do, but, if you look at it from the care gap perspective, what are the things, Dr. Chetna, that we should be doing to improve the care for patients, cancer patients, and, what are your suggestions?
So to reduce the care gap, as I said, we should have cancer centers or doctors, in a remote places also. This is one thing, so that patients need not travel. Then even if I think now government has started those things, we need to train the doctors. Even if there are no oncologists in those places, but we can train them to give chemotherapy, so that when patient comes here, we can diagnose them and tell them that this is the protocol which can be given in their places. That will really reduce the gap which is there nowadays we are seeing.
Right.
Secondly, which is not in our hands, but we need to reduce the costings, especially for cancer drugs, which will also help in reducing this gap which we see in the treatment. So these are two things which are really a requirement of the day, and I don't know how to do it, but these things are, I
These are
think,
the
which we need. Yes.
right.
And obviously public awareness, because more and more awareness is there, more and more awareness camps are there, people will be coming to the doctor, because most of the time people do not come to the doctor at all. So they should know. But abhi to, at least in Bombay, we see they come. There are
They
so
come.
many ladies I see who just come for breast examination. They say, no, I feel that it is something, and you please examine. So that is really one good thing which I'm seeing increasingly, and
So
which
they
really
come
makes us
to
happy.
so they come to a gynae, or they come to an
So,
oncologist?
at least being a female oncologist, many of the ladies come to me. So, in my daily OPD, at least I see one such lady who do not have anything, who's young also, sometimes 29, 30. They do not have any family history, but they have heard about something, and they come to me and they say, you please examine me. I just want to reassure myself. So, daily one patient I see, I'm in Thane, I work in Thane, and I work in Jupiter Hospital. So these many educated ladies who work in IT companies or wherever, they come and get themselves examined, which is really good.
Right. Yeah, but it's interesting to me that they come straight to an oncologist and don't go to a gynae
Yeah,
or
in fact,
something.
many times I tell them, now you have come to me. After this, there's no need to come to me. You please go to your physician. That's what I keep on telling them.
Right. Right. And Anuradha ji, in terms of what can be done to improve care options like rehabilitation and psychosocial care.
Yes, so first and foremost is like, it is, we have to create an awareness amongst our professionals, like,
Right.
that there is something, a lot much that we can do and contribute in this field. Like, as I told you, like, since oncology is not a big topic of included in the curriculum, there are still lot many therapists, occupational therapists, physiotherapists who are not really interested in entering this field, or who are not totally aware that yes, what is our role in treating cancer
Mm,
patients, like,
mm,
so we have taken care, and like, we have started this oncophysiotherapy training at Tata Memorial Hospital. So we have 5 trainees and twice intake in a year, and so far we have trained about 100 therapists across the country. So this is like building a network of oncophysiotherapists, so therapists who are trained in treating cancer patients. So like, even it will be easy for us to access or refer these patients when they go to their hometown, or try to find some oncophysiotherapist nearby whom at least they can, like, and now with teleconsultation in this, like, many of the patients can even use this teleconsultation facility, to find out the access. But understanding and making the therapist aware is also very important. Another thing is like, as she told, like, there has to be a financial, because see, even rehabilitation area, it is a long term, like, continuous investment, like, it is like, at least the cancer treatment, the chemotherapy after some cycles can stop, like, and may not, the patients may not to go. But suppose, for if I'm treating a lymphedema patient, their compression garment or their bandages, it gets worn off after a certain period of time and have to be replaced, so that again requires some kind of monetary investment. And unfortunately, many of these rehabilitation aspects which are costly, are not included in any insurance or health schemes.
Yes.
And that
yes.
Right.
is where the failure is, like,
Right.
because there is no compensation, or there is no source from where these patients can again and again, like, get some kind of aid for them. They just tend to stop doing it, or like, wearing, donning on those processes or this, like, so that is one area where everybody has to really look into. And like, hopefully from our end we are trying, because like Tata being an institute can get some funds from somewhere or the other, as a CSR or as a donation. But I think in other hospitals, like, that
It has
gap
to
is a
be,
big gap.
yeah.
It's a huge
I mean, for
gap that
instance, it should be part of the, the Ayushman Bharat package, for
Yeah.
instance,
yes,
So,
yes,
in fact, even oncologists should be made aware of this, that they should include the physiotherapist in
correct.
whatever, treatment, as a holistic treatment. Like when we
yes.
have our tumor board, we generally have medical oncologist, radiation, and surgical oncologist. But ideally, I actually agree with her. We should have a physiotherapist also.
Yes,
So
we
that
should
I
have a
think in Jupiter.
physiotherapist, and ideally sooner rather than later, psycho-oncologist as
Yes,
well.
yes,
So,
yes.
Yes,
So in
definitely.
Jupiter, we are actually planning to do that. I mean, we are still discussing those things. This happens in Tata, but everywhere it's not available.
Not
But
no.
we
available.
should start doing it, and we'll do it only when we are aware that, okay, we need their help and they should be there in our tumor board.
Correct, correct. And as before the webinar, I was talking to Anuradha ji that one of the big challenges we see patients have is that they don't know, who is a trained physiotherapist. They
Right.
go to any physiotherapist, but that doesn't always work. They don't know the specifics of lymphedema or
Yeah, right.
things like that. So that is one of the big challenges that we hear from patients and survivors as well. And sometimes, some of these things don't hit you right away, right? They hit you sometimes a few months later,
Right.
and then they don't know who to go and ask for help as well.
Right.
So that's a big issue. um, any final words from both of you? Dr. Chetna, first with you. I
So
know we've covered a lot of ground today, but
yes, yes. In fact, this is very good thing what you have started, I must say. So thank you for that. This is one thing. And secondly, yes, we should. I think we should focus on reducing the care gap, cancer care gap, and everybody. If all of us we try from our side, even little if we do, that should help.
right. Thank you so much, Dr. Chetna. Anuradha ji?
Yeah. First, let me thank you for including me. It was a very wonderful forum, like, and where we could really express our need, desire, and our, whatever drawbacks and everything. But the thing is, like, as Dr. Chetna said, yes, from everyone's end, we have to try to bridge the gap, like, in the caregiver. We have already started it with training our the different therapists. But I would say that, considering the treatment of cancer as a multidisciplinary should be initiated, because
Right.
I think now everybody are functioning at an individual level, whereas I think cancer care basically is a very holistic approach, and it
Right.
requires all the disciplines of not only the medical fraternity but also the rehabilitation. So that means it has to be like, there has to be a psychologist, there has to be a medical social worker, a physiotherapist, a speech therapist, an occupational therapist, a dietitian, all of them, like, and in fact, like, we had two international conferences on multidisciplinary which we conducted in TMH in 2017 and 2019, which was a huge success, where 7 rehabilitation disciplines came together and hosted this conference. Like,
Oh,
so
that's
I
very
think
nice.
many such things should be done, so that that concept that it is not just one
Right.
discipline that is working towards a care, but it is the entire forum that has to come join hands
Right.
together and fight this dreadful disease. And that's what I feel should be my
Thank you. Thank you so much, Dr. Chetna and Dr. And Anuradha ji. And I think we've had Dr. Jyoti as well initially. I think a few key points that have been made. Obviously, the earlier we get diagnosed, the better the outcome. So I think as lay persons who are watching this, please remember that getting an early diagnosis, starting treatment early is the best approach. And there are options even for coverage. So please do explore them. As I think also as outcomes improve over the years, survivorship becomes a bigger issue. So therefore, it's important to look at holistic and rehabilitation of patients and survivors, because and as Anuradha ji said, that should be a multidisciplinary approach. And again, as individuals, as patients, as survivors, make the effort to reach out to us to find out resources that may be there in your city, in your town. As we've said, that there are increasingly options, not enough, but at least there are, the progress is in the right direction. And I think as a community of people working in the space, we should come together to emphasize what things that can be done to improve uh, the survivorship and the quality of life, as well as reduce care gap, and also see how some of these things can be included in the various care packages, because otherwise, all of these things cost. As Anuradha ji said, the consumables like compression bandages, etc., cost. We know that things like stoma bags are expensive. So all of these things need to be factored into the various packages as well. So thank you so much once again, Dr. Chetna and Anuradha ji, and to our audience for listening to us, and to Pfizer for supporting this discussion.
Thank you
Stop.
so much.
thank you
Thank
so
you.
much.